Good morning. Welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 96. What a lovely introduction that was. Congratulations to the people who have put in the new introduction. I will take a moment this morning to talk about the recent conclusion of the 20th annual Complex Coronary and Structural Symposium that we finished last week. For those of you who attend numerous meetings, it would have been obvious what striking difference this particular meeting presents. You will get a first-hand appreciation of truly complex coronary interventions. And this year was as remarkable as the other sessions. I have been attending these meetings for the last almost 20 years, and it is truly amazing how in a span of 6 or 7 hours you are able to see possibly the best collection of the most complex coronary interventions performed skillfully, safely, as well as with very pragmatic didactics. So for many of you who are venturing on taking a day out of your busy practices, in addition the fellows who can also come and attend the fellows board review course, I strongly, sincerely and passionately recommend to you possibly what I have witnessed over the last 2 decades, the smartest and the best interventional cardiology course. I would also like to congratulate both Dr. Sharma and Dr. Kini for having performed this amazing journey for 2 decades now and hopefully counting. Lastly, to the nurses, the technicians and the fellows, it is your hard work which makes it a seamless transition, and congratulations to all of you. With those words, let's take you to another exceedingly difficult and challenging case, one involving exceedingly difficult calcified total occlusion of the LAD. And should we be able to traverse this difficult course, there is a further bifurcation also to handle. With these words, Samin and Anu, congratulations, 20 years of the most amazing journey.
Well, Samir, thank you for the great and kind words, and truly this 20th year was really spectacular in terms of the cases which we presented, and more important, the international faculty, and we combining the endovascular with the 2 days and so, but truly remarkable, and that is what we want to show, that made it 1 day and did total 14 cases with the 3 tower on that day. And show the complex of the complexity and how technical tips can be given to people so they can use in their own practice. Of course, some of the cases which we did, we say that don't try it at home. So those cases need to come at the centers, but majority of them still the technical tips will make or would have made all the interventionalists, those who attended, but definitely a safer interventionalist. Also, that the all activity of the CCVVC 20th episode, 20th year will be available on the website, and probably they will say it may take up to 2 months. So all the lectures, all the live cases, everything will be available on the website. The board review questions are available now because we know that they have to take the exam sooner. So interventional board review questions are available, but everything else will be available probably in 2 months.
I think the people attending, as well as I am sure the viewers who watch our show, can appreciate your tremendous skills. And Anu, I have gone on record as stating it is absolutely a delight, as it was a delight during the meeting to watch your skills, your expertise. You know, a lot of these cases look so difficult and challenging, yet there is a perfect synergy there. You've established a straightforward, replicable algorithm how to tackle that, and step by step you took them through it. I was amazed at the simplicity and the pragmatism of your Bifurcate app, and I truly believe that this meeting should be foremost on the agenda of most interventional fellows, as well as numerous people takes just a day out of your practice, come and attend this meeting and you'll come back greatly benefiting.
You want to comment?
Thank you. And you know, same thing I always say for us, as much as we want to, I think the most important passion for both of us, myself and Dr. Sharma, is that whatever we have learned, that I learned from him, and whatever I have developed the skills myself, want to teach other people so that other people will gain from the knowledge that we have, and it will be passed on to the generation after generation. That is something that we do, and hopefully we will be able to continue for decades and decades.
Look, not only that, as a final word, Samin's passion, the energy and the humor in doing these cases is absolutely unbelievable.
I did a lot of jokes. Okay, now let's get ready for our
This
case
is
number
another
96.
away from the jokes. This one is a serious business.
This
You
is
have a
serious
seriously difficult case today.
Yeah. Now see this, we actually made the new website for our CCC live cases, new and improved, and of course with the barcode, so that can do it, you know, take it to the website directly, and it has been enhanced and put all our together, complex coronary cases, which is every month, live peripheral interventions, 4th Wednesday at 8 a.m. and structural heart live cases every other month.
And
so
to add, we are live on YouTube.
And the live on
yeah,
YouTube.
we were live on YouTube,
Yeah.
and I wanted to tell you what is on the YouTube. I had so many comments from India actually. A lot of people watching, and since it was on the YouTube and it is available immediately.
Yeah.
Yeah.
That's true. And we continue to hold our 5,000 plus, the 5 to 6,000 plus our monthly episodes. You know, it takes a few months to get on, and most of our success is in the archived, and that is okay. So we may not have that many live people logging in, but they are going back using this our CCC live webcast as their teaching tool, learning tool, and incorporate in their practice over 128 countries. So it has been a superb.
Half a million page views already.
That's it, over 500,000, yeah. And these are our supporters, the disclosures, and basically this case, quickly we want to start episode number 96 with a 62-year-old male who presented with new onset Canadian class 3 angina with a strongly positive stress test for moderate inferior and anterior ischemia. A cardiac cath revealed 3 vessel disease, which we'll show you, and with a high syntax score and moderate to severe LV dysfunction, and patient had a heart team discussion, which is really important for these cases. They should not have an ad hoc PCI as per the guidelines, and this patient had a good discussion with the surgeon, with a cardiologist, and they decided that we'll go for the PCI rather than CABG, although that was the recommendation from our side also. So now Anu has taken the picture, patient is on good medical therapy, and you see the angiogram starting.
Oh, we didn't do an LV. Oh,
But
there
that's
is
fine.
a-
Yeah,
we have.
Clearly
And
the EF is now around, is still about
showed
30.
it's viable, most areas.
And it's
most of the
ischemic,
viability, yeah,
ischemic and viable. RCA had a large stent, which is very good, this RPL.
And it's
Yes.
essentially filling majority of the diagonal, and this is the dual injection. Same thing I would say, go RAO low mag, and you see the LED as well as
They're
the diag.
massive super dominant, right? There
Yes.
appeared a lesion there in the mid to distal segment, or did I?
Yeah, no, it was
It
there.
was
It was
moderate,
there
yeah.
also about 50,
Okay.
60%, maybe
Alright.
look a little more now, but
Right.
it was always there about 50% and so.
So there is a lot of bridging also in the LED. If you see tram track, heavy calcium, and you see some bridging collateral. But the question is the same, that when you are doing a total occlusion, just because there's bridging collateral, you know, don't get fooled that okay, let me do antegrade without dual injection, because as soon as you have your catheter right there at the proximal LAD and you bring your wire, then you may not see any flow through the bridge collateral, and you will never see any antegrade flow. You definitely need a dual injection to make sure distally you are in the lumen if you get through the distal cap.
Yeah, and the other question was, in this particular case, with the low ejection fraction around 30, with the 3 vessel, you have better picture of the circumflex also, or no?
We didn't take a caudal picture.
OM, we
No.
are not taking a picture yet, but we'll come to that circumflex as a part 2, rather than going, it's a very significant lesion in the circ also, which will be also need to revascularize. So by our algorithm of the EF of 30% with the Protect 2, It's a protected PCI, appropriate case for impella, but problem comes when you already need contralateral injection. How do you do? So I think what our goal is, let's try to recanalize the LED. We already have a sheath with a pre-close, and if it require that once we recanalize, then we can upgrade that to the impella, which is appropriate in this particular case.
Contralateral from the transradial and impella from the other groin.
Yeah, but again, then we have 3 punctures, which is okay. We do sometimes, but we are modified.
Symposium we did that.
Yeah, in the symposium we did it exactly what you said. So with that note,
and the question would be the same, even since you know, even if we are able, if we cross it, there's so much of heavy calcium.
Right.
Then we have to consider any kind of you know, atherectomy here. And we know we were actually predicting, if worst comes to worst, if we may have to consider a laser.
Laser or orbital, yeah. The plan is to do orbital atherectomy once we cross, is the particular case. So while we are getting ready for recanalization, we can go back to our slide set, which is good medical therapy, and these are our high syntax score. STS also calculated mortality of 2.2 in this particular case. Because after that heart team discussion, patient had PCI of the large RPL, and then now here for multivessel stage PCI of the CTO LED, circumflex OM2 using orbital atherectomy, DES with OCT guidance, and plus minus impella support with the LV assist. So now from the guideline point of view, first thing you need to do is that complex and unprotected left main, which is syntax score more than 32, and III Vessel CAD in diabetics. Those patients should have syntax as well as STS, because high STS of 5 and above brings you more to a favor of the PCI, and so clearly this is the particular case has a less than 5 STS score, so that is appropriate. Secondly, for the 2 vessel disease group point of view, intermediate risk positive stress test, medical therapy on 2 medications, so this will appropriate for the PCI point of view. So with that note, just quickly knowing that today is our focus on the CTO. So we actually had numerous publications since about 5-6 months ago. We presented the data on the CTO, and those are the 2 important points I am going to speak. One is the CTO recanalization predictors, that is there any new, because all have 2 have come in last 3 months, and update in the long-term outcomes of the CTO PCI. We love to do it, we do it. Is it supported by the data, need to be seen. So clearly the recanalization predictor, many of them has been as shown in this slide. The most important, and it started with the JCTO score, having a previously failed lesion, blunt stump type, bending, calcification, and occlusion length more than 20. So clearly you can have point from 0 to 5, and it actually has been shown that you can make it a simple JCTO score sheet print out. So every case you could predict that whether this patient would be in terms of difficulty. They say difficulty in crossing the lesion in 30 minutes. So whether it's easy, which is 0, intermediate, which is 1, difficult is 2, and very difficult is more than 3, and so 3 or above. And this actually has been validated by many studies that it really makes sense. Very difficult, of course, it takes a longer time to cross compared to the simple JCTO score. Since then, there have been many other scores, again into the same line, particularly and also incorporating severely calcified lesion and previous CABG and so, and non-LED CTO, again both in the derivation validation set from France. Clearly, the more complex it is, that's where your the success rate goes down. And another one from the Progress CTO, which was the global registry of the chronic total occlusion score, and basically you see that if there is no intervention collateral, so intervention collaterals just comes up recently along with the proximal cap ambiguity. So clearly those are the 2 important things which were added on with the Progress CTO, that if you don't have any interventional collateral, why? Because the retrograde, because we know the antegrade will have 70% success, another 20-25% will be from the retrograde. And of course the proximal cap ambiguity, which is PCA or ambiguous proximal cap, we call APC, basically means if it is not a funnel shape, so you don't know where it is going to go, how the distal tract, many times there is a side branch at that level. So clearly this remains the issue and has come up as one of the adverse predictor as shown here. So now in this month's journal, JACC intervention, Another hybrid approach for CTO and predictors have come up, and they basically focus on the ambiguous proximal cap. Whether it's a cap is ambiguous yes or no. That basically means that yes means that you just have a blunt stump, and no means you have a tapered. Once you are tapered, then your usual comes under your length, ostial, distal target, and individual operator. But if there is ambiguous proximal cap, then of course various factors comes with the collateral circulation and tortuosity, and of course the calcium adds on. So they came up with this new algorithm, and predicting seems to be a better predictor than the progress CTO and JCTO score. They compare the C statistics was much higher, and so on and so forth. So basically these were the seven. Ambiguous cap on the top, then operator preference or operator expertise, reference vessel less than 2, moderate to severe calcium, poor distal target, worse collateral score, and actually they got the collateral of the retrograde as well as the classical Werner's classification of the collateral, which talks about the googliness of corkscrew type of collaterals, and of course excessive tortuosity. All these 7 new factors have come up, and they say that this model is better than the existing one. Only problem is that the collateral grading is so difficult, it cannot be probably done by everybody else. So this is actually nice editorial talking about there, and point is that you need to go for the CTO cases to the expert operators, and so on and so forth is very, very important, and these are the 7 points. So clearly with that note, Dr. Anu has already crossed it. Anu, you want to say something what's going on now?
No, we crossed it. I
Then
think he did have, no, it's not going.
Yeah.
So this is exactly like how we had the case during the conference.
One second. Yeah. Yeah. So they were, tell us which wire.
No, this was a Gaia. You did ask me a question, why Gaia? So if you see there, it was beaking. The proximal edge was beaking, in which situation the Gaia wire is better off to start with. Between the two, since Gaia wire, as you see, one, it has a composite core, which is I think during the symposium we did show the slides of the wire by the side, and it has a tapered tip, which is very helpful in this kind of situation. So,
and this is the key. So this is the case, will be no ambiguous proximal cap, because it's a clear cut proximal cap, and the funnel shape, and that actually is shown by most of the studies that basically increases the success rate. Now what you do is, after your wire has gone, you corkscrew your the fine cross, as you see here. Is this okay, or you need to go more?
Little bit more.
Okay. See that? See my hands?
Yeah.
And now many people go with the Corsair, which is fine. But to me, the Corsair is okay. But I think this fine cross really works very well in this situation. Good. We take it out to the rotor wire. Orbital atherectomy wire. Yeah.
Orbital. Okay.
Yeah.
Get us that orbital wire.
Samin, tell me, why not rotor blade here? Why orbital?
Yeah, could be rotor
Could be.
blade.
I think we should do rota, I would say, because
but
we may have to go with the 1.5, but
Yeah, no, but that's okay. But the 1.5 will give you that. You need more, or that's okay, right?
I think so. Let me see. Rota wire probably is better off.
I know this is 6 or 7 French.
Yeah,
No,
it's a
we
6
went
French.
with 6 French.
Yeah.
See, that's another thing we always remember. Everywhere else, people like to do this kind of tough
Orbital
cases with the 7 French, 8 French
So
CTO.
this would commit you with the bifurcation if you need to be
Yeah,
with the
bifurcation
decay.
would be orbital.
Orbital.
Oh no, rota. What do you want?
Orbital.
Orbital, okay.
he wants.
Yeah.
This is good. We want to show.
Yeah. Take that out. Bye bye.
So did you need much manipulations with the Gaia wire, or?
A little bit, not. I mean,
Yeah, you know
that's a very important question you asked.
But question is the same. Little bit means 12 seconds for Anu.
Well, we saw her cross that incredibly difficult proximal tortuous calcified subtotal left circumflex in 3 seconds.
3:30.
Oh, room 3.
Yeah, which I know one of the people in the audience asked you. Look, it's no doubt. Both of you, your skills are paramount, but more than the skills, I think it is also the judgment and the step-by-step approach.
do an impella quickly.
Long time ago, you had told me that I should start tweaking, so you can tell people what is going on in your mind.
Absolutely. I
But
think
there are good and bad things, you know.
look, it's
Put the sheath in now.
No, for the impella.
Yeah. Yeah, good. This is good. Good.
So we will upgrade to impella before we do the.
so the good thing is we can now, if people who are not terribly familiar or have some doubts, let's show you how quickly an impella
Can be inserted.
in 2017, 9 years after our doing our first case, how easy it has become. Once again, the reason being that when you are in the most complex and challenging part of the case, this patient will benefit from LV support.
Good. So while they are putting the impella, let's go back to our discussion.
So with the impella, did you just the picture which you took with the micro catheter is enough for the anatomy, or?
Oh yeah, they did a picture in the beginning.
Okay, so that's good enough.
Remember, we cannot do pre-close unless we know the artery is okay, not calcified. So these things done. So now we'll take it out. We'll take out
what
and
kind
put
of
the
wire
impella
is not
sheath.
going inside because the no flush or what? It is not going. No, that's not the one wire.
Samin, I have several observations and
Which wire they gave us?
No, this is
Are you sure?
a laser wire you gave us? No.
No, not the laser.
The viper.
Yeah.
Coronary viper for OA.
Not going. Yeah. No.
The very important point, just to make sure that you are
Go.
OA wire is the correct wire.
Yeah. Exactly.
So they have a peripheral viper also.
Yeah.
all small tips for people to learn from.
What was the question earlier? Because I was just asking.
Yeah, no, I had some questions and some comments for you.
Yeah.
I mean,
You are asking some questions.
Yeah, it looks like you know, being I don't want to sound sarcastic about it, but looks no big deal coming out with the CTO score. You know, the three which you have talked about, the JCTO, the one coming from the proximal cap by LS, and the progress. I'm sure with your thousands of CTOs you do, you could come up with your much more pragmatic score.
Yeah, but many of these scores are still at the same the common denominator.
Right.
And common denominator basically the tortuosity and calcification. And of course the lesion length we always know is one of the important factor.
Well, I would like to add to that about you know, this
Experience. No, experience of the operator is very important. Like the recent Steve Ellis paper, there's one operator G had actually very high failure rate. So clearly that operator experience is also at paramount importance, particularly for the CTO. We know that for many other disease processes, but CTO also.
Which is exactly what Nick Lembo has emphasized in his editorial.
Yes, absolutely. Okay, with that note, while they are going to show the live insertion, as soon as the sheath has been inserted, we'll come back to it and we'll continue our discussion about the CTO long-term outcomes. Now you see that very conflicting report, whether opening the CTO successfully is going to improve your long-term outcome. And as actually you see here that some studies are going to show plus, some showing no benefit. Now this is a complete revascularization. So clearly that you have a better outcome once you have complete and successful recanalization. This is the data from European, from Europe, from the data. Then second came from Park, 4.6 year follow-up of the CTO presented last year and showed no difference in mortality. Yes, successful CTO will decrease your TVR and CABG rate, but overall no difference in all-cause mortality in this almost close to 5-year trial. Then the latest data from the, then question always comes, what about the collaterals? Your ST segment elevation, whether collateral have anything importance, collateral have any impact on the subsequent outcome, particularly in the STEMI patient, because we know STEMI vessel, when they get collaterals, they do better, well, that's the infarct related artery. But what if non-infarct related artery gets the collateral? So what is the, these are the data showing that in the STEMI patient, if you grade the collateral to the non-infarct related artery, better the collateral, better is the outcome, and so which makes sense. And then lastly, the latest data come 3 months ago from the VA. We continue this, from the VA program, and the CTO successful and no successful, and it shows that 25% of the patients who come to the cath lab have a CTO, and of them, once you decide about in this group, 80% success rate and 20% failure rate. And basically that once you have successful CTO, you have a better survival compared to if you're unsuccessful. So again, little different than the UK registry, where there was no difference, and here we have a difference in favor of the successful CTO. 2-year MI, 2-year mortality, 2-year CABG, all were better in the patients where you have successful CTO versus failed CTO. Failed CTO occurred in about 20% of cases. And of course, once you have failed CTO, you have a higher complication, which we all know. So therefore, it seems to be that some data yes, some data no. These are all the non-randomized trial. So what about the randomized trial? The 3 randomized trials which are shown in our lectures here, Explore, DECISION-CTO and Europe CTO. The 2 of them have been completed and presented. The 3rd one, Euro CTO, I was told that just about getting completion, and we'll have a 3-year data of the solid endpoint of the MI and death. So Explore trial basically was the short trial of the 4-month follow-up in the patient with the STEMI who had a CTO. So they do a CTO PCI within 1 week or no CTO PCI, and they followed the 300 patients for various endpoints, particularly of the left ventricular ejection fraction, and EDP was identical, no difference, presented last year and published after the TCT, and no difference in individual outcome. Now the DECISION-CTO major trial was presented in ACC of this year from Korea again by Park, and optimal medical therapy with or without stenting for CTO. The trial supposed to have 1284 patients, but was prematurely stopped because of poor enrollment. But we have about 800 and change cases which had a 3-year and 5-year follow-up, 3-year in about 93% and 5-year in about 85% of cases. Success rate was about 91%, 25% were retrograde approach, and basically the trial showed that 3 years optimal medical therapy or PCI has an exactly identical outcome, 19.6 or 20.6 in terms of death, MI and revascularization, 3-year MACE as shown here. Death, MI, stroke and any repeat revascularization was exactly identical even at 5 years. So 3-year and 5-year exactly outcome, very disappointing, very, very disappointing, showing that the PCI did not show any benefit in the large series of cases. Now we can go back to the fluoro quickly and show that how quickly the Impala has been inserted after upgrading the sheath. Anu, you want to just make it a point? Yeah. What did it do? The sheath increase and so?
Nothing. Sheath was same. We had a 8 French sheath with the pre-close. That was already done. Let me show you we have the groin shot. Yeah, this is the groin. Oh, this is the groin shot. So if you see here, the groin, nice, non-calcified, large size femoral arteries. So we did a pre-close and left the 8 French sheath, and we used it for contralateral injection with the 5 French catheter. And now once we cross, we just change it to the Impella, which is again 14th French sheath, peel away sheath, and then we have the Impella inserted. Yep,
within 5 minutes Impella is working now.
Augmentation about 1.7, 1.8.
Yeah, we are about 1.5, 1.6. Very important here. EDP was just about 14, 16. I think you remember when we did the live case that we had the Impella and a lot of suction going on. Halfway through the case, the pressure was dropping.
Damp,
yeah. So that we found out is because so much of suction from the Impella. So we haven't gone full. What, Pablo? What's the speed you have?
I have it in
P?
1.5 on P9.
P9?
No, but why 1.5? We should at least 2.
This is the max.
No,
It's a 2.5.
Yeah, but even, I mean, 2
No,
to
that may be
2.2.
because the EDP is low, no?
Yeah, but still, but anyway, to me, remember I say Impella versus Impella CP. These kind of cases you don't need CP because the 1 French higher and few extra $1,000. So this kind of case, getting your output around 2 liter additional, which is good enough. So they are already ready.
No, they're
and
saying there's some leak.
on what? Okay,
OA.
so they're going to work it now. So let's go back to our slides while we are getting our OA ready. That just to say, very disappointing, although there have been a lot of letters since then, particularly because if you see here that in terms of mortality, see the mortality in the PCI group was non-statistically numerically lower, almost about 3 points plus, and then over 2.5 plus. So the whole idea was that maybe PCI decreased mortality, but you know, once you have a negative trial, you try to make any positive out of it is not important, because repeat revascularization, everything was lower. What really was important was good trend towards lower CVA rate in the PCI group. Again, you say, why? Medical therapy versus PCI, why there should be lower CVA? But whatever it is, basically shows that PCI did not harm, but it did not benefit based on the DECISION-CTO trial. And so even with the intention to treat cases, other parameters, they have quality of life measures were not different. So now only one group remains, is the what about instant restenosis, chronic total occlusion of the stent. So another paper published few months ago of the ISCTO, they basically showed that if you take ISCTO or no ISCTO, you basically have a bad outcome of the ISCTO compared to the native vessel CTO. Now the success rate and complication rates were not different, but the MACE rate was almost almost 70% lower in the instant CTO compared to the native de novo CTO, and largely driven by the TVR. So basically shows that CTO you can open of the instant, but it is associated with the higher TVR rate. Authors give various mechanisms for it, because that can occur because of thrombosis or various other factors. And so last just I wanted to put is the radial vascular access site. Again, the data from the British cardiovascular intervention of the CTO done by the radial versus femoral approach, and you can see that overall the CTO procedures are done less and less because of the absolute indication, more because medical therapy works. Secondly, the femoral punctures are becoming less, almost 40+% cases in Britain are being done by the radial approach, and many times they have the double radial for CTO for the contralateral. Now, if you take femoral and radial, these are the various procedural outcomes, and more important is look at the vascular access site complication is much lower with the radial versus femoral, and why it is, then procedural success and others are not different. There was decrease in the no difference in mortality, but what was there was the access site complication was significantly lower with the femoral with a similar success rate. Now what does that mean? Because access site complication is the one really kills the patients. The mortality at 1 year when you have access site complication is 4.7 versus half when you have the no access site complication among the various other items. And of course we know higher access site complication occur with the femoral approach. So therefore there may be some I would say little reprieve for the radial our operators, that yes, that sometimes doing a radial CTO may be helpful. Yeah. Okay. With that note, we are ready here. Anu, tell us where you are now.
OA now.
Okay.
Same.
The OA is basically two speeds, 80,000 and 120. We use 80,000 RPMs. 120 I say that should be contraindicated unless you could not open your lesion. So just to and fro, 1 millimeter per second passage, and you ablate both going forward and coming back. Yeah.
Well, Samin, many questions about your presentation, because the DECISION-CTO has now left a huge area which will need to be clarified, explained. I'm sure the trialists are going to go completely berserk with the information coming out of DECISION-CTO, because if the CTO at the end of 3 years is not showing clear benefits, then why undertake such a difficult process? But
yeah, and I mean very important, because remember the O trial.
Right.
O trial showed that routine opening of the CTOs even in MI setting after 48 hours was wrong, and it made a class level 3.
Right.
So clearly we are worried about if you have one more negative trial, and it will be a major issue Now you have one more negative trial of the CTO, it will make the guidelines may come. The CTO PCI should not be done.
Look, it's there are so many questions, and one of them is I'm quite surprised when you mentioned that the trial was stopped prematurely because lack of enrollment. Why should it be hard to enroll CTO patients?
Yeah, no, basically the same. Because remember, the issue comes, those who are a believer of the CTO, they basically say that we are going to do CTO anyway. So now you saw it, we are done 5 times back and forth, slow movement, and that is the technique of the orbital atherectomy. And of course, you get a different gain or better gain when you advance multiple times, and you get an even further gain if you go to high speed. Problem with the high speed is that is what associated with the perforation. So by and large, my teaching is that do not use 120,000 RPM. The new device, which is called micro crown, the speeds there is 50 and 80,000. So clearly that it's a very effective device, and you don't need to go to a higher speed. Now hemodynamically, how patient did? Anu?
Anu,
No change in,
so a question for you here is, how does the wiper wire compare to handling the rota wire?
I think it's same. I would say which wire that you've been used to and comfortable with.
So as
now one thing is, we are coming back. You have to be very careful with this device. Many times, I would say 50% of the time the wire comes out.
Okay.
Yeah.
So I'm
negotiating through the lesions and all that. Since we have been used to the rota wire for years together, rota wire still is a preferred. But you know,
as a completely unbiased observer, my question to you is, why is truly, I watch you do hundreds of cases with the rotational ablation. In what way does orbital appear to be easier?
Yeah.
There's one, definitely in the rota there's a learning curve for the rota.
I understand.
There are a lot of things. One, you need to have your leg with the with the rota, the pedal that you have to press, and then your fingers moving the rota, which means you have 2 things going on at the same time.
The real, Samin,
there is some hemodynamic
slope.
Right,
changes.
which is
even when you're doing rota, when you're in the tough case, you will see some hypotension, bradycardia that you see, and as soon as that happens, for the beginners, they just stop doing the procedure.
So all related to really the distal embolization and the slow flow which rota can cause probably more.
I think if you do it right,
then there is no issue.
Yeah.
No, but point is for the beginning interventionist. That's the question is asking. Now question is that, you know what, we cannot have the exact number except the industry. Reason is, when you make it for the ACC and CDR, they count atherectomy as a group, and you cannot have a differentiation. And in this particular case, have you shown the angiogram that you should take care of the diagonal also?
We will.
Yeah,
we will, but
we don't know what is the verdict, but according to industry sources, at present in USA, there is a 50% market share of the rota and orbital atherectomy. But this is just industry source. I think we should wire the diagonal.
We have to take a better picture of the diag. But there are many cases, what I will say, rota has to be done rather than orbital atherectomy. The biggest, which nobody talks about, but I think I will tell you, that was our paper which showed what kind of a calcific lesion and how this atherectomy device actually works, is our OCT paper which showed that for orbital atherectomy, which the biggest concern for orbital atherectomy is that perforation that happens. Why you go high bank? Okay, go.
20 you need.
When you are
doing what we have seen, that in these cases that you need at least 3 quadrants of calcium. If you don't see 3 quadrants of calcium, the mechanism by which orbital atherectomy works, which is that it orbits around. So if you have mild calcium, moderate calcium, 2 quadrant of calcium, it will be deflected to the quadrant which there is no calcium, and that is where you will have. No, I can do with the fielder, I think. That's where we can have perforation. So that's the key. Like here, we knew that it was tram track calcium, if you can see that.
No, which is true, which is why by your previous demonstration of so many cases I had raised the possibility of even considering rotational.
Yeah.
How do you Anu, so when you are removing the orbital, you should do it on fluoro so that the wire is not lost?
Yeah, wire doesn't come out.
Samin, we see the diagonal there, what you were mentioning about.
Yeah.
Two
big diagonal.
2-5 vessel, yeah.
Yeah. So I think we are going to wire it and then of course do a balloon, whether we need to do some different crush technique or so.
Medina 111.
Yeah.
Now diagonal.
Actually, we saw the diagonal filling by the collaterals only earlier.
Right. So once again those magical fingers getting
There may
the,
be actually a
There's
tight
another
lesion here.
Yeah, 1.512.
yeah, it's
1.512
Right.
or 2 or 12?
Some
You want to
di-
see the last picture? No, see the picture first. You'll need a balloon
Good.
support. Yeah. So 1.5 or 2 or 12?
I think 2 or 12.
2 or 12.
It's a big diag.
Yeah.
I have often wondered if rotational ablation has not really gotten a stepchild treatment through industry. You know, the wire has hardly been developed, education has been lackluster, and it really, you know, people I think just got scared too easily.
Yeah. Yeah. No, but just open that one lesion a little bit. Yeah. So no, clearly, no, just open the subtotal. Yeah. So key was that now at least finally they are doing something, and that is called a Rota Pro, which is with the FDA. And here is the same thing. They have copied what is the orbital atherectomy. Everything on the table. All the connections and so no foot pedal. They come with a cart which has little oxygen, nitrogen tank directly, and so forth. So we learned that this multitude of issues when you have to do the pedal, the tachometer, all those things are issues. So all those will be eliminated. Wire pulse or what?
Yeah, somehow that's a calcium, some dye.
Yeah, that's the apical calcium.
Yeah.
So competition does amazing things, huh?
Yes.
Yeah.
Yeah, this is calcified apex, and we saw it. There was no good. Let's go up.
Go. Yeah.
I'm
There was
seeing
no LV thrombus, but there was always a little calcium at the apex. Calcified thrombus. Yeah, you have to go a little distal also.
the patient hemodynamically has been doing
Yeah,
all
it's
right.
just about 100 down. I think we did okay, no? You want more? Go up here. 6, 8. Yeah, good. Down.
Samin, what was from
Ready?
your operator points of view, both of you individually, I'm asking the question, which case during the symposium did you find most interesting and educational?
Yeah. No, I think, but you're right, that which exactly the case, to me that challenging right coronary artery was really the big, very difficult case. Then of course, that after PTC of that LED diagonal, that after balloon dilatation, we went back with the 1.5 bar because nothing will make turn in that bifurcation LED diagonal system. So to me, I think that really tops my case, in my opinion, that LED diagonal bifurcation with the top of the left main case, which we did.
Anu, which case did you find most intriguing and interesting?
Let's open that again.
Yeah. No, I think our CTO that turned out to be a bifurcation.
Right.
And don't forget the structural. Our structural case, which was the valve in valve, which
Right.
the valve was released in less than 30 seconds. The third case.
Look,
And placement of our cerebral protection device.
right, I thought that was very elegantly done, although, you know, there were statements which were made in that case. I think you made it look much simpler. That was not half as easy as it turned out to be, and I think in the middle of a questionable trial, I think that's where the balance is. You have to be very careful in choosing which case
Which case
best to,
you can do it,
right.
yeah.
So overall, I thought once again we go back to, you know, it's to be doing the patient's hand is, yeah, okay.
Okay, right.
You know, to do so many cases one after the other going through seamlessly was truly amazing.
Yeah.
And
it is what I say is it is just another day for us here, another Tuesday, except there are no cameramen around us.
absolutely, I'm
That is why it is so seamless.
I'm a witness to that, and you know, so many people when they schedule a case like this, they have to discuss amongst themselves, read all the materials and the journals, and go and see our website for similar cases. This was flawless.
Yeah. So that's why I always go with the 30. Yeah, good here. Okay, we are going here. There is a watermelon seed effect
Yes.
on the balloon, despite having a 2 wire at that level, because one going into the diagonal.
So what, angiosculpt or
We'll see.
cutting?
Hopefully now we have pulled back a lot. Okay, down. Let me pull back. No, it will open. Down.
Pull the wire slightly back here. LED wire.
No. Okay. Yeah. Pull back here.
Good.
Okay, go.
But look for a 2.5 angiosculpt.
Down. 3O.
Yeah. Huh?
3O, no?
Okay.
This is a 3O balloon.
Yeah. 3O angiosculpt.
What size? Didn't we say 20? Okay, go up here. Go up. I think we'll be okay. We are almost very down.
There keeps
taking it out.
slipping back.
Take it out or take a picture or what do you want?
Okay, another Sinai. You got to decide what you want to do to the diagonal.
Yeah.
Watched up.
I'm sure some people would make a case for leaving, doing a provisional, but the ostium is now looking a little, and of course the LAD of course needs a lot more attention.
Let's put the diagonal wire into the top branch. That's a bigger branch. Let's take this wire out anyways. I mean balloon. We are not doing its job.
Why we have such bad dissection
Yeah,
of LED?
very impressive.
Same cut with the orbital. Yeah. It's very rare that we used to get this kind of
I
dissection.
thought it had more to do with the way the watermelon effect was going back and forth, but
Okay. Well, step by step now. You want to go wire into the top branch of the diagonal, or we want to open the proximally first? I think we should open
I
the
think
proximally first.
the wire looks okay there, no?
Yeah.
Forget the diagonal.
Yeah.
No
Okay, let's
casting.
open the proximal,
Yeah,
and then we
like that.
decide, are we going to stent the diag?
No.
Yeah.
Diag, we still do a long 2.5 balloon, 30. Yeah.
Reason is that since big dissection flap is there in the LED, we may lose it completely.
Yeah, that is true also.
I think we have to stent it. Let's go review the angiogram, how it was after we did the OA. Not bad.
Samin, how is what's going to be the next step towards answering such a critical question about the need for CTO and what has emerged after DECISION-CTO?
Yeah, I know. I think we still, that European, the CTO study is still, we are waiting, and that's truly of the death and MI at 3 years, the real hard endpoint.
It could be the death of a procedure.
Yep, if we really have that, it will be a trouble, yes.
Okay, some die now that we have to handle this.
Yeah, go to the superior branch. Yeah. Good. Yeah. Okay, you want to leave this wire? 1 second.
It does not, it keeps coming out.
I know.
Congratulations also. I have Dr. Kini just told me you've done your 1000th TAVR.
Yes. Yesterday. This is trio.
After starting several years behind several established centers.
Down, down. It does not work. You want to go shorter, smaller? 3O may be too big.
Yeah. No, about 308 high pressure. Right?
I think we are struggling because
Well, I go back to the question. I don't think this would have been happening with the rotablator.
100%, and the dissection probably related to this one.
Absolutely, you know, a much cleaner, efficient ablation of a truly, genuinely calcified lesion. Would you still consider?
You know,
No,
Okay,
opened up.
here it
Down.
opened up now. That does it, yeah.
16.
Oh, consider rota now?
Yeah, it's
No,
not with
after
that
the
dissection.
dissection,
Yeah,
yeah,
not with that
probably
dissection. Truly, correct.
Same thing after the balloon dilatation, we had dissection in our LED diagonal case, and we showed that how you just do the rota of the proximal segment
Right. Stay
without
away.
going to the dissection area.
Right. But you know, one could also argue that a dissection angiographically can be inapparent also.
Yeah,
Very tricky to, okay, excellent flow now.
good. No,
That-
let me rehabilitate the diagonal first now. So far so good. No, but go to the proximal area where the have you opened proximally.
Of which one? LED?
LED at the level of the septum.
Listen, it's a dissecting. We may
Yeah, I know.
dissect into the left main. Let's just do the diag. Put a stent in the diag now.
No, the balloon first. Okay. You want to but open the proximal area. Let's go back. Whether we have opened the dissected area there. Go this one. Go there.
Let's go caudal.
The one at the level of the large septum.
We are approaching into the left main. Anything we touch, this guy is bad dissection.
Okay. Give little die that we are out of the circ. Very little. Good.
No.
Pull back more now.
See, now left main.
Yeah. Left main always was a mild. Okay. Ready?
Ready. Okay. Are we going to come all the way to the left main?
No.
No, then don't dilate here.
No, but we are
Let's
far
take a
away from the
Sinai.
left
It
main.
slipped
Let's
back,
take a
slipped
second.
back
Before
again.
you know.
Yeah.
Because we don't have a
We are
caudal
far
feature.
away from the left main.
Yeah, slipped.
See, we are far away. Good. Let's go in now. Open that just before the catheter. Yeah. Let me go up now.
All right, that opened nicely there.
Now.
Good, done.
Go a few millimeter in, and then we go to the diagonal. I will say that let's see we
Go.
can salvage the diagonal. Probably it's unlikely that it's going to work here. Good.
This is what I say, do not waste time.
No,
Put
not
a stent,
waste.
come out, and
I
then
know,
we just
I know,
take
I know,
all
I
of the LED and come back.
Yeah. Okay. Done. Out.
Done?
Yep.
So possibly 2 long stents in the LED.
Yeah.
One
Yeah.
won't cover. Yeah.
Okay. You have that balloon, long balloon. 2530. Yeah, that's the one. Yeah. Good. Let's keep this one on one side. You will do a DK crash or what?
Yeah.
Okay. Good. Go.
You have the wire?
Yep. So what we are basically is trying to tack up the dissection.
Yes.
So this case is will going to get very complicated with the 2 additional stent in the LED. If you put another 1 or 2 stent in the diagonal, get the wire over the diagonal more. Yeah.
So how are you approaching the diagonal?
Right now it's a 2.530, and that's our technique that you inflate first, go to whatever atmosphere full inflation, and then cut it down to half. Leave it for a few seconds so that you tack up those dissection channels
It's
which
not
we
few
have created.
seconds, you need minimum 3 minutes, by which
Yeah.
time you can go to some other room and come back.
Yeah. Okay.
So it's the concept of almost a modified perfusion balloon strategy.
Yes.
That's it. Yeah. Good.
Yeah, yeah. This is
Come back. With the Sharma speed. Yeah, that's
please.
good.
That's what I meant. Okay, go.
Yeah, Sharma 3 minute is unknown.
Okay, down. Get the stent. 32, 38.
Anu, for the
2.5.
viewers, take them
38.
through this.
2538. What are
Yeah.
viewers?
take them through the steps of the DK crush?
Yes, I will. 1 second. But now
Ready?
let me just.
I'm going
let's,
to magnify
decide.
now. Yeah.
No. You won't see the distal vessel. No.
Okay.
Okay. Good.
Ready?
See the okay. Wire.
Samin, your intent of putting in the superior branch is a good idea. It's a large vessel.
Okay.
Pull back again.
That's good.
Yeah. So 30, right? Yeah, 38.
Yeah, 38.
So what we will do is now we will go with the stent into the diag, and then we will place a balloon in the LED. What balloon we have? No, we can't take 8. Longer. 3015 we had,
Or
right?
20.
Oh, 3020. But
Yep.
okay.
And at
So we will place the.
2.5 or 2.75 in the diagonal?
We are putting 2.5.
2538.
Yeah, that looks okay.
I think this wire might have come back. Oh, see. So then what you do is place, once you are there, you will inflate the side branch stent with at least a millimeter sticking out. Definitely you want the stent into the main vessel, a part of a millimeter of the stent into the main vessel. Then you take out your balloon as well as the wire of the side branch out. Then the whatever you have in the LED, the balloon, you will inflate it to crush that stent. Then we recross. Kiss, that's the first kiss.
And the benefit is this is all 6 French compatible.
Yeah.
And now the challenge of
Calcium.
getting the stent there, yeah, some
is more.
fleck.
Ask him deep breath. This is another shit. Deep breath. This is, I think, the proximal calcium.
Yeah, which is where
2.5
Samin
angiogram.
was trying to dilate there also.
Yeah.
I think.
It's nothing to do with the diag, I think. Nothing to do with the diag.
Yeah, 2.5.
What?
Let's get 2.5 angiosculpt.
Or you want a guideliner?
No, this is not guideline case. No.
Yeah, you still have
No,
some
you have to just crack there. That's it.
residual.
At that area. That we can get same 2.5 balloon. We can go high pressure.
Yeah.
It's this thing is that's not allowing. Nothing
Yeah.
to do with the diagonal.
No, it's the ostial diagonal. Yeah. Anyway, give us back. Give us a 2.5 angiosculpt.
And you're going to do it including the
At the
ostium.
ostium, yeah, ostium of the diagonal, proximally, and in the main LED. That's where
Also.
she.
I am saying it's the proximal calcium that's not allowing the stent to go further down. That maybe just go with the guideliner now.
No, but you have 2
Although
wires.
the wire
Guideliner with the 2 wires will be very difficult. Yeah. And
But
here.
at least place the balloon, you know. This is not going to do anything.
Good. Look for a 2.75 15 high pressure also. Yeah, good.
Go.
Hold it there.
Why? I
In
mean,
case if it doesn't go. Yeah, good.
So this is the angiosculpt for the diagonal ostium.
down.
Yeah. Now question is, this is kind of case, you always ask the question in the past that why angiosculpt and why not flexstone, because here we may need to go to high pressure. So that's where I think the angiosculpt comes in.
okay, down.
Yeah, and then do the LED now.
Proximal, no?
Yep. Yep.
Go up here.
How high had you gone there?
Go up.
Yeah, so I went to 14,
Okay.
and I think we'll go a few millimeter more and stent will go.
A little more proximal also.
Yeah.
Go up here.
Yeah, but more important, you have to go back to the ostium after we open this here.
Get the stent ready.
Yeah, we have it. Yeah.
So you're predicting it is going to go through easily now.
Yeah.
Go
Ostium.
up.
You'll put 2 millimeter back. Good.
And a little
That's
higher
it.
now.
That's it.
This is the problem.
We may have to put a brake on the stent.
How high there now?
Same, 12 atmosphere.
Okay.
Nicely opened up, 12 to 14. One area. Yeah, this is the
still-
one I went earlier,
And
right?
there's still, you know,
Gritty.
gritty. Okay, go up.
Don't go one more.
Go.
18. Okay, I'm going to go to 18 atmosphere now.
Down.
And that is just about the maximum you should know.
Yep, that side.
Okay.
Good.
Guideline are ready.
You won't need it.
I remember there was a very nice guideliner RCA case too.
Yeah. See a little die?
Exactly.
Some die, yeah. There's another problem with the angiosculp also.
The wire sticks out.
You take it out. Okay, going to the side branch. Now the tip is gone. What are you-
No, the tip might have been destroyed. You want to? No, that's okay.
That's okay.
Good. Ready?
Yeah.
Okay. Good. When it curls up in these hydrophilic wires is always the best for us. We will give you the proximal portion, which is the extra strength. Find out what's happening in room 3 and where is the barman. All right, see to believe it.
Samin, I am seeing a mild stain there distally around the apical area.
No, but that
It's
is the
just
calcium which we saw
okay,
even
yeah.
the LV gram.
I had a feeling, okay.
Yes, yes.
So went easily,
Good.
Yeah.
exactly as predicted. So you're going to come back about 1 or 2
Yeah, we'll
millimeters
do
into
after
the
we
LED.
put a LED balloon. Yeah.
Now LED balloon.
Yeah.
Foolproof osteal coverage.
That is the key.
Right.
Key for the two-stent approach is the coverage of ostium. Achilles heel. Every time, every trial, even the double stent trials earlier with the cipher, they all have high restenosis at the ostium because two stents were given bad name because you missed the ostium. And that's why the whole DK crush and culotte they have come in, that you have a guaranteed coverage of the ostium.
I think even the mini crush.
Yeah. The mini crush, yes.
Yeah. So
But
three
remember, there is
things.
no true mini crush trial which showed much benefit. Good.
That's because Europeans believe in DK crush.
No, there actually DK crush is used
Good.
very little.
Here,
You want to take a picture,
Full
so
on.
show it?
I think we are good now.
Yeah,
right?
but show the picture.
Ready? Oof,
Good.
it's too much sticking out, sticking into the LED.
Yeah,
I'm going to go in a little
1
bit.
millimeter you
yeah.
can go in, yeah.
But see how
Yeah.
we have roughed up the entire LED diagonal.
Which is okay.
Yeah,
Just little die.
little die.
Fluoro.
Yeah, I think I went in a little bit.
Good. Ready?
Yeah.
So
Go.
the precise, I mean, look, this is a lot of experience, borderline some guesswork also, but the only way you would come to know whether you got it right was during the recrossing, no?
Down.
Yeah.
Recrossing?
No, we'll know
No,
it.
you'll
that
see it now. When
osteo-
I take out and I crush the stent, you will see it.
Right.
that jumbled up
Yeah.
shadow.
Appearance, okay.
Now what I also do, pull back inside. Yeah, good here. The open of the ostium,
Yeah.
little high pressure. Now you can go 20. All that
Okay,
doesn't
down.
mean anything because you are going to crush it.
This part is not in our
I know.
app.
Yeah.
Good.
This is the additional
Sharma's
Kini
modification
step.
of the
Kini
DK
step,
crash.
yeah.
Then the steps will go up more.
Yeah. Good.
Okay, now you see that the wire has to come out, very, very important step. See, this wire has to come out.
Samin, I just
New.
coined.
And then go up with the LED.
I coined a new terminology just
Go up.
now, SKS.
Yeah.
Sharma Kini step.
Yeah. 14, 16. Good. Good. Negative. New fielder wire.
Down.
This wire is gone. Don't use this wire now.
New
Take
fielder
both
wire.
of
Go up
them-
again.
Both of them out.
What I'm saying, if you are describing the step, then you have to continue.
How high are you there now?
18. Negative. LED we
Though
get a 3
they don't mention this.
Oh, take this out now.
Yeah, we will take everything. Wait. Okay. Good. All this will come out now. Now get us a new fielder. Since we know that fielder has been beaten up a lot, will go recross with a new fielder and then get us a 2012 balloon, right? The only thing different that I want to do compared to what is described is when you recross, they want a NC balloon to be recrossed 1:1 vessel size.
Yeah, which
it doesn't
30%
happen,
of the
yeah.
time will not do it. Press this one down and take a picture. Let's show the picture.
Yeah, it's just a dissected LED. Why you want to see it?
Okay. Good. Truly, indeed, the marathon case of episode 96.
Look, very educational. There were, it was challenging.
I don't think in our 96 cases that we have done, you have ever seen a vessel that is beaten up like this.
Okay.
I
Why don't you
attribute
start,
it.
we are going to
Do you,
OCT. It's a
Samir, do you
OCT
remember?
case.
No, no.
Yeah, OCT
Right
is
now,
that.
for what?
No,
Then
this is
one
what
No,
happened.
To see stent fully expanded.
That's okay. No.
Radial dissection.
Yes?
I can, just having watched these completely unbiased, I think rotational ablation was the way to go. It just leaves you with a much better handling of the calcification, and but on the other hand, I think this is exactly the kind of cases you want to show people how you handle. I think if you
now.
go back.
By the time you magnify, we cross a side branch.
Yeah, that's okay.
Yeah.
So we are to a balloon. We are all to a balloon.
And Samin had picked up the very proximal area, and it's
Now, ideally, you should kiss, right?
No, first open first. Yeah, no.
Get
kiss.
this, no?
Open
Again,
first.
modify.
Yeah.
Okay, so the first case will be,
No, right now we're just opening the ostium. Then we had two balloons we need.
for what?
3 and the kiss. This is just for
Exactly.
opening.
Then give it, we go in.
No, this one, no. Didn't we say that first you are going to use a non-compliant balloon?
Oh, then you want to go again?
I mean a compliant
Please.
balloon. Yeah.
We'll
Why?
be here the whole day.
No, but will it go otherwise?
Yeah, just kiss with this and come out. That's the modification we are talking about. Okay, news. This is the used balloon, right?
Or it's a 2O only?
Okay, good.
Yeah.
Go.
Good.
My only question, I am telling you, SS, if you have dilated the side branch without a main vessel balloon, there are cases then we cannot get the main vessel also in. Balloon.
Good. Now we put out two balloons. Say which balloons you want.
Get us a 2.5 NC, go up. 2.5, 12 NC. And then what is a, give us a 3020 for the LED.
Good. Yeah, now this step, the question is it needed? Because we know that once you have this much the crush, you may require a compliant balloon first before you go to non-compliant, because KISS has to be done with a non-compliant balloon. That's a very important, because the whole purpose of the KISS was that you are going to open the side branch ostium.
So the later recrossing is easier.
Easier. And not only that, one, and secondly,
Yeah,
they
opening
have
of
shown
the
by the
ostium.
IVUS, the ostium of the side branch is much better open with a decay crush because of this first kissing inflation.
Samin, I happen to believe that it's not like you open a textbook and try to exactly follow their steps. There are so many variations in the case that you end up modifying. With that basic strategy of decay crush, there are individual maneuvering which may be needed.
Yeah, absolutely. Now the wire has come back, so the only question will remain: are you going to throw the same strut where you have opened it nicely?
Right. It may go through a different cell.
That always the issue happens.
In which case you'll have to use the NC balloon again.
Yep, compliant, yeah. So right now we have the 2.5 new non-compliant balloon for the side branch. You need a new wire. I think the wire has been beaten up.
It just went in first time. That is why mini crush is a better technique. Be home long time ago. Okay, let's go.
What do you want? New wire?
Why are we having this? Oh, we went to a different strut. Different strut looks like.
Good. Now K is same. You go put your wire into the LED first, and then you pull back and go to the side branch. Yeah, good. This is the one.
Yes, fantastic skills with the wire. Excellent.
Good. Okay. We got another wire, 3O balloon.
Okay, now what should be the stent? 275, right? LED? I think 3O is
3O.
big.
3O. No, LED 3O.
SS, I think
We
if
have
this
the low
balloon
mag.
has been used
We have
100
the low
times,
mag.
get a new balloon.
For the LED.
Yeah.
No, this
But
one will
it's
go.
multiple
Oh, okay.
times. It will not
Give
go,
us a
wire
new,
will come out.
new 3O20 then. Go. Okay, you want to see the LED size?
I think so, because I think 3O was too big. That's the reason. Look at the size of the distal.
Okay. So 275, 38.
You probably need to get it proximally to about 2 or 3 or 4 millimeter
Right.
after the
proximal will be
origin,
unoverlapped and
of
that
the
will be good.
circumflex. Yeah.
Yes. Take that.
Okay.
What balloon do you have in the?
So we have a 2.5 high pressure balloon
go.
in the diag and a 3.0 high pressure balloon in the LED. This is the case. This is the first case.
The ostium has been nicely
Why they
opened
don't
with a
mention the first crush? It's only double kiss crush.
Yeah, crush is only one time.
No, first time you did, no, with LED, but they don't, in your definition it doesn't come. Done?
Good. Yep.
Okay. Now I take the diagonal wire out, right?
Yep.
Everything comes out and give me the stent. Oh, let this wire stay there. Hopefully we'll be able to recross again. Get me the.
I mean, what is to say that a triple crush would not be better than the double crush? And a quadruple not better than the triple and the double. I mean, this is just.
Good. Okay. Ready
Truly,
for
I
LED
think
step?
the only practical benefit is it's 6 French compatible. The rest is all hocus pocus.
I've told you.
Hocus
That's why
pocus.
I think in the 96 cases we have never shown it. We are showing something that should not be done in the 96th case.
Yeah. Okay, we need to see what is the distal landing zone of this stent.
Uh-oh. Wires are like 100 times coming out. Now don't tell me we are out of the dissection.
Let's see.
Some die. Oh yeah, bad.
We headed in the false lumen.
Yeah.
New wire. Pull back few millimeter. Yeah. Give us a new run through, or you want a whisper?
No.
Take the last picture first. See it.
You want to take us in a?
No, not now. Okay, you take us in it.
Probably the dissection starts almost at the level of the diagonal.
Yep.
Probably a new wire, no? I mean, this would.
I think the wire tip and everything has been gone. You have the other wire. You want to go with that wire? You already have one wire there.
Let me try 1 second.
Out, no? Out with that wire? Yeah.
Yeah. So you have put that wire into the diagonal already for the time being. Keep this distant. We are going to need it in a few
Tell
minutes.
You pull everything out. See?
So with the dissection and trying to cross this, what is the safest wire there now?
To me, whisper.
Okay.
Now you need a hydrophilic.
Yeah. To seek
No,
the
which wire you want?
seek the lumen.
Yeah. Although the Boston Scientific other wire Marvel also we start using, but I have not tried into the dissected areas.
Yeah, you mentioned about it during the course too.
Okay. Let me show you.
As easy as that, huh? It's in the.
Let me take the things out. Every time the device you pull, you're pulling the wire.
Anu, what wire was this?
Please.
What wire was this?
That was the fielder of the side branch.
Fielder with the Kini technique.
Yeah.
Okay.
The barman can do it, or he's on the phone all the time.
So now we will go to the LED stand.
So here for our viewers, you just got a sense of what truly happens behind the scenes and how this is such an amazing procedure people watch. I mean, it's one case being done, and Dr. Sharma's attention on other processes occurring in the cath lab. Busy cath labs, other procedures have to be done, patients are waiting, other attendings are waiting. It's just I have truly over the years enjoyed how beautifully this process is handled. All right, that looks to be far enough, distal enough.
Yeah, okay, go.
This is 275,
And
38
the
Promus.
healing will start right here. This is, here we go, and expanded well enough distally.
14.
Down. Go up again. I think I need another new fielder to get into the diag.
So the two-step expansion of the stent, the first expands it and the second one does the opposition.
Yep, that's it. So you need a little distal massage in this, because it's a multiple dissected channel, so it's 2 atmosphere distally.
See first before you want to do
Okay,
it.
you want to take a picture?
Yeah.
Good.
The key
Exactly
is the
right. Huh?
It's a smooth out. This is smooth out.
LED diag, LED
go. Yeah.
finally looking
So
good.
Samin, this is, I have another new word for it. This is DAP.
Yeah.
Go.
Not tap, but DAP. Distal.
You can give vasodilators and the vessel will plump up.
Right.
But you know, there is a vertical plaque shift, just the 2 atmospheres, you're not causing any problem there.
And keeping it low atmosphere, you're trying to prevent any intimal flaps.
That's it. Okay.
Okay, let's see your corner. You want to put another proximal stent. Now we need to see if we need a proximal stent in the LED.
You certainly do, I think.
No, we need. Yeah, that's a separate part. Good.
Ready?
Looking good.
So some contained.
Yeah, there is something in the.
Yeah, there is a, you know, besides the apical, that shadow, there is a small wire cut from the diagonal.
I had spotted something there. I wasn't sure.
Okay.
So angiomax goes off.
No, I think this is okay.
You'll continue,
Yeah.
okay?
Okay. So let's decide our strategy now.
You have to put a proximal stent first, right?
Yep. No, first you do kiss. I think do the kiss now. Go back to epicranial, we do a kiss.
And then you need a 3
Yeah, yeah. Then we do proximal later. Yeah.
What would be the issue if, let's say, you did the proximal part of the stent and then
no, but
went back?
anyway,
And
clearly that, remember, going through the second stent and will create a problem. Right now we just had to do a quick kiss. Yeah, yeah.
got it.
Okay, we already have a 3O balloon. We have already 2.5 balloon. That's it. We'll just use the same one. Yeah.
NC will go.
It's the same step.
Maybe a little slight wire-related spasm in
Yeah,
the
this-
segment distal to the stent
So
also.
that will be right. Yeah, this is the new shadow now. Remember one at the 3 o'clock has been there before?
Yeah, this is the new
Yeah,
one.
this is the new one at the wire. But you know, these wire going into, particularly hydrophilic wire, into the small branches. Want to go to exactly our view earlier?
Yeah, go to the same view.
So, won't another wire track back into that stained area?
Same
Yeah.
thing keeps coming back.
You can put this wire into the LED and put that LED wire into the diagram. So,
Okay, that issue is solved.
yep. Good. You just leave it there. Okay. Put a wire in the side branch, balloon in the side branch first, using the same 2.5,
Yeah.
or we need a new one.
2.12.
I think let's try.
It's not going to go, I'll tell you now.
Then what?
Okay, we'll try.
Then what
I
do we
don't
do?
know. Give me a new one.
Which one? Compliant, non-compliant,
Get us a non-compliant,
or
right?
2 compliant?
We had, right?
No, but new. If you want new, that get a 2 or 12 compliant.
I think I don't. Yeah, give us a new one. 2 or 12.
And we are going to come back to this.
And for the LED,
Again, you want to go and see?
That's okay. I mean, this one
Please.
now will be all right.
Yeah. Let's just finish
And
this
we have
now.
a 3O ready.
We have a 308 fresh one and a 320 used one.
You can use a fresh one. If you have 308, why not?
The tower is ready for.
Go.
Okay, get us a new
No, we have 308, yeah. Or
8.
you want 320? We have
320.
320, yeah. Good.
compliant or non-compliant? No?
LED will be non-compliant.
Non-compliant.
In the side branch, we have a compliant, non-compliant. Yeah.
Although we could have put, what is this?
No, I don't want 820. Here, 3020 we have.
Yeah.
What should be the stent for the proximal? 16, 3016 or
I think it will be 20.
3 or 24? 20.
Yeah.
3020 quickly.
Yeah.
You will overlap it with the distal stent?
Yeah, we can overlap. Yeah, no, we should. And
Yeah.
particularly now, we will be few millimeter away from the bifurcation.
Right.
Too far.
Okay, go. Go, Chris. Don't get crazy. Down. See, even then it slipped. You saw the diagonal
Pull back.
slipped.
Yeah.
Okay, good. Go.
This you can go high pressure 20, and LED may be moderate.
Down.
It will move.
Down.
Again slipped a little bit.
Yeah.
Okay. Let's do a
Serial.
kiss now. Good. Now you go 6, 8. 8 maybe. Yeah, good. Stay down.
Good. Okay, get done.
You want to see now? Side branch.
The two balloons will be difficult to visualize.
I want to take out everything except the
LED.
LED.
Okay. Keep particularly 3O balloon ready. Good. And take a picture and then decide the picture in 2 views. Want to give nitro now?
No, give, go.
Good.
Well, distal vessel is looking exceedingly good now without
That's good,
without any vasodilatation requirement. That dissection is an impressive dissection, huh?
Proximal, yeah.
Proximal.
But that was a very calcific vessel,
Yeah,
which
to start with.
That's okay. But bifurcation looks beautiful.
So 3 or 20 to cover that whole area, or
20 or 24. Let's see
24?
now. Our regular measurement. Yeah.
You see there's something there?
lengthwise
No, no, forget it. Let's focus on this.
and then stop the angiomax quickly.
What is that?
Yeah, we can stop the angiomax and we'll just put a stent.
Yeah.
Yeah.
No, we are okay. No?
Okay. 20, 24, which one we do? Good. 20 right now. Good.
You bring it almost next to the origin of the ostium of the
Yeah.
circumflex.
Which is fine. So once we do, then we are done, and then we end up our this marathon PCI. You change the view. You just see the ostium.
Too long, no?
Hmm?
Too long.
Too long?
Yeah. I told you 16.
No. Let's see.
Somewhere.
Pull back. No. Yeah.
Coming up to the ostium or?
No, no. You have to bring it to the ostium. Take a picture. You want to magnify?
No need. I think we are good.
Okay.
See?
No, but it's not too long.
It is.
No, why? 2 millimeters. 60 will be too small. But anyway, it looks good.
No, you
You don't want to, aren't you too
think we have to
proximal
go in a
there?
little bit.
Huh?
In a little bit.
Little
because you
distal,
still
yeah.
have circumflex to take care.
Yeah.
Guide, bring the monitor down a little bit.
Remember, stent is inside the marker.
I know, but still too much. Moderate left main disease, right?
Yeah.
Okay, some dye. Yeah, see?
Yeah,
Too
needs
much in the-
another 3
Ready?
or 4 millimeter.
Okay.
Wait. Okay. SSC.
Good.
You have to go in.
Okay. Nanomillimeter.
Yeah, some dye. Okay, good. Go up now.
Okay. 14, 16. Good.
For the first time, it
Down.
dilated without any issue.
Yes. Go up again and then we'll go overlap.
Didn't cover the ostium of the diagonal. Hmm?
Good. Good, good, good.
Go up,
That's moderate pressure.
down.
Okay, we take a picture and then that should be it.
You've stopped the angiomax in the meantime?
Yeah, we are done.
Ready? Take one picture here.
No nitro? No.
Nothing.
Okay. Epicrania. That shadow is persistent.
Yeah.
It's okay as long as it doesn't increase. Yeah.
You won't, I mean, these, just that the increased flow has now highlighted the circumflex lesion
Yes.
looks wonderful, no?
Beautiful.
The very large diagonal with the
So magnified view.
2 branches and
Okay, ready?
yeah,
What is
that
that vessel that you're seeing?
There is another diagonal probably.
Or is it a branch of the LPL?
Yeah, LPL. Actually, that's what we are seeing the collateral, even to the circumflex now. But this is
Right.
good. LED diagonal system and all that has been done.
So
with
just to Samin, just so that viewers are left with the sense of comfort. So you'll take another repeat, another picture in about 15 minutes or something, and see that it is
Yeah,
the
2
stain
things
is-
we will do. Plus, we will get an echo here in
Got
the
it,
room.
got it.
Just
That's
make
all.
sure everything is okay.
That's what I needed to ask.
That will be done.
Excellent,
And-
excellent.
And it will take about 10 minutes to close and sew
Perfect.
the impala and sew. Ready?
And the impella will be removed in the cath lab.
Yes.
That's right.
Excellent result there. Both the diagonal and the LED
No,
looks
I think
good.
the lower branch of the diag.
Yeah.
That's the lower branch of the diag. You're seeing a late filling
Yeah,
vessel,
yeah.
not anymore. Yeah.
What happened here?
Computer also is tired.
Okay, so just we quickly finish it. The numerous, our take-home message, the predictors of successful CTO recanalization and long-term outcomes of CTO PCI. The numerous reports have highlighted the predictors of successful CTO recanalization, which can be incorporated in daily interventional practice to predict the procedural success. This enables us to provide procedural assurance to the treated patient and can help in better planning the interventional time slot. If you have a high risk score, you know that maybe 2-3 hours compared to low score, it may take half hour. Then there have been conflicting reports of favorable impact of successful CTO recanalization on long-term mortality. 2 randomized clinical trials comparing CTO PCI versus optimal medical therapy have failed to show any signal of positive MACE outcomes after PCI over maximum medical therapy alone. Hence, CTO PCI should only be done with clear indications of cardiac symptoms and or ischemia on non-invasive testing. Our 3 questions following are the favorable predictors of CTO recanalization except, means what is wrong? Ambiguous proximal cap, LED CTO, lesion length less than 10, first PCI attempt, well-developed collaterals. Second, DECISION-CTO PCI trial reported following favorable outcomes of CTO PCI over medical therapy: lower mortality, lower MI, higher CVA, lower TLR, and none of the above. The last one, following statements are true for instant restenosis CTO PCI versus native CTO PCI, except that IS CTO PCI had lower procedural success, IS CTO PCI had higher complications, IS CTO PCI has higher MACE, IS CTO PCI has higher TVR on C and D. So clearly these questions are there, and I'm glad that we have excellent results, although it took us a little extra time, little late start, but case came out perfect.
With this, we conclude today's transmission. Samin and Anu, congratulations for another good case and another 20th year of your live cases symposium. We'll see you session number 97 on July the 18th.